Appreciate great information. So now that the next few minutes, what we're going to do is see two cases. The first one's going to be the RECOR Paradise system in action, and then the next one will be the Medtronic Simplicity Spiral system. So can we cue that up? George, you want to come on
catheter, which is just a catheter to the level of the diaphragm and inject it to really visualize the renal arteries and the parenchyma to make sure there's no, first of all, the location of the artery. Second of all, to look for any atherosclerosis of the renal artery, and also to identify whether how the vessels are, and also possibly how often they branch and what the caliber of the vessels are. So,
Yeah.
So here we go. So this is the first picture of the kidney. Important in this picture is to rule out any significant stenosis, which there's not. Also to look at the renal, make sure that the entire kidney is visualized, making sure that obviously there's no parts of the kidney that are cut off, because if that's the truth, then what may happen is that you may have an accessory renal artery. This is also very good because you can size the kidney, and you don't need to do intravascular ultrasound to size the kidney. You can make either what we call as quality vascular assessment by measuring, or you can do an eyeball sizing of the kidney, which has been done for years, meaning of the artery, which has been done for years. But what we're planning on doing here, because it's available in our lab and it's 100% not necessary, is to do an intravascular ultrasound.
Is there a way to pause this just for 1 second?
Now, I would use, based on the pigtail catheter, which is just a catheter.
Okay. Yeah, so just while, it was playing, I think it's important to go over just a couple technical aspects. So you're going to use, you use your standard 7 French renal guide, whatever you feel comfortable with, 014. And then I think one of the anatomic features that you see in the renal angiogram that probably pertains more to the RECOR system than to spiral is the length of the
really
main renal artery
and
a long main segment, and then you want to avoid the bifurcation if you're adhering to the same rules as the trial. So you have a nice segment there, and then I think PK is going to do what I think a lot of us recommend, particularly with the system, and that's to use IVUS so that you're not guessing what the size of the artery is, because you need to have good contact, but not so much that you mess up the artery and not so little that you're not effective in your therapy. Okay, go ahead and let it play.
Sure apposition of the device up against the vessel wall. So here the apposition will be ensured with a 6mm balloon. The other thing I want you to watch for is the branching. and as we know with the Paradise system, there is no reason to go to all different branches. So you can see here you have a large bifurcation. So we're going to stay proximal to the bifurcation. Is that okay? Decided to go with a 6mm catheter. So that catheter is being delivered to us, and that's the delivery console. And you can see by the writings, it's remote, cartridge, coolant, cable, and catheter. And of course, it's a very intuitive thing. So the catheter gets plugged in, and then this is not normal saline, this is water, right guys? So this is sterile water that's going to cool the balloon. So therefore it's important that that's also something that everybody's aware of. It's not normal saline, it's sterile water.
I don't know if you can zoom in or not, but there's actually 2 dots that shows you where the electrical connection is. You just have to line it up, and then once it's snapped in, you have to connect it so the 2 dots meet up, and then you know that the system is ready. There's also 2, what the saline flush, where it runs to kind of fuel the cooling system. There's 2 plugs, which is very intuitive. You just kind of connect it here, make sure the connection is tight, and then through this last port, you just flush heparinized saline. And then the catheter will be prepped.
It's very intuitive. The setup is very fast and easy. And the delivery of the therapy is also very predictable because you can ensure apposition on the vessel, by testing, and I'll demonstrate how to do that. So very, very simple. I don't think you need IVUS. I want to emphasize that, but I think that if you have it, it's reasonable. I don't think it's unreasonable to use it. Same time, I don't think it's mandatory for the success of this device. So now we are going to go ahead and prime the device. The 6mm catheter has been detected, and now we're going to go ahead and prime it. So he's going to, now the prep, it's very intuitive. You press a button and it's prepping the catheter. The balloon is inflating and deflating, actually causing the beauty is that now you're prepping the catheter and removing all the air. So it takes all the guesswork out of whether you got all the air out or not, because the machine is so intuitive that it does it for you, and it's actually quite easy. This is probably the longest part of the procedure, but again, I think it's reasonable because you don't want any air in the system, so the wait is actually worth it. And in the meantime, right now, obviously, you're just waiting for this to prep. And you can see the prepping cycle is almost over. And you can visualize that how the bubbles are being, removed, but negative suction, and actually, redoing inflation and deflation to remove all the air in the system. We're just going to go ahead and introduce. And the important part here is that we don't want to deliver therapy across a branch point. So you're going to see us give a little bit of dye just to make sure the branch point is not affected, please.
Yeah, so this is an important part, and it's just to make sure that you're opposed, so you'll just do a little flash of contrast, make sure nothing escapes, and usually we start, distal and come proximal, and as long as nothing's leaking around the balloon, then you're set to apply the energy.
Flow past the balloon now. So now we're going to go ahead and deliver therapy. So you can see it first cools, and you can see I have both of them on. You can't really see the balloon inflate here. It's cool, and now you can see in 7 seconds it's delivering therapy, and you'll see it now. It's done. I'll allow it to deflate, and then I'm going to pull it back 1 balloon length.
Yes, it's roughly about 12
Okay, now when you get the green check mark, you know it's done. And I'm going to pull this back a little bit more about there, gentlemen. Everybody happy? See my...
Yes.
Yep, right there. And then next. And then it's perfect. So we're going to go up here now.
Okay.
So again, it's now inflating again.
So just from a patient perspective, so I don't have the same number of cases under my belt as Dr. Sharp, but in limited experience, the pain is just a couple seconds towards the end. It's not, there's not a lot of pain the entire time. It's just right at the tail end. So I've actually been pleasantly surprised about how much sedation you actually need.
Yeah, for the ultrasound device, the energy ramps up and peaks around 2.5 seconds. So the patient will start to become aware of it. And if you just count down, they almost always tolerate it. So I just give 1 or 2 milligrams of midazolam and 25-50 of fentanyl, and that's usually enough for everybody.
Yep.
I just go ahead and give it because it's out of habit. Being an interventional cardiologist, tend to give nitroglycerin. So we're just going to give a little bit of nitroglycerin. No, because I'm not going to come back to this side. So the question was whether I want to wait to give to the other side. My point is I've delivered therapy in this kidney. I just want to give the nitro to this kidney. Okay. Go ahead, flush. Good. So nitro is given to now flush saline for me. Yeah. So we deliver the kidney, flush the saline. Very good. So now we're just going to walk the wire back. And then we're going to take a picture. Fill it now.
Yep.
Fill it. Mm-hmm.
Yep.
Okay, excellent. All right.
Hold on. It's
DSA?
refilling. It's refilling. Yep.
You have enough dye?
Yes.
Okay. Okay. And so in this picture, we're looking for any spasm of any vessels. There's absolutely no spasm. There's no dissection. There's a wonderful, delivery of contrast.
Is a pretty, pretty straightforward.
Can you mute for now? Can you mute and stop the video?
Plug, which ends up
Oh, I can do it right here. I'm sorry, I didn't know I can do it right here. Okay, so guys, I think a couple of things there for the panel. As Dr. Sharp knows, you are allowed to go out to the distal vessels, and we obviously didn't show it for the sake of time, and you want to go ahead and move the wire into the large enough vessels to be able to deliver the therapy and then come back. You do not want to go across a branch point, so it's important. So if the vessel size is adequate enough, you do want to go out and do it. Second thing that we've seen with this, I think we've done, I don't know how many we've done, I think the RECOR guys would know, we've done a few now, and the idea is that, you know, the pain that the patient feels is literally for the last 2 seconds of the delivery of the current, or the therapy, I should say. So therefore, you know, it's important to really kind of distract the patient, talk to the patient, and they will feel that, but it lasts so short that it's really not even significant. You know, and the third thing is, again, a good angiographic technique of engaging the vessel properly first. You know, no-touch technique is what we use in our cardiac cath lab. If you want to use telescopic technique, that's fine. Please don't assume that just because the patients are young, you can take a guide and put it inside the vessel. We never do that. And of course, atraumatic guide wires and judicious, you know, wiring of the vessels. Generally, the device is incredibly trackable. As George would tell you, that we were able to get it to the point without a problem, you know, and deliver the therapy. I mean, we've never had a problem tracking the catheter through. The second thing is also having enough renal guides. I know a lot of you are not, I mean, none of us have really done renal angioplasty in the last few years. So have different sets of guides. You know, and also if you could do pre-op imaging of some sort, maybe of, you know, or even a diagnostic of, you know, do a flush angiogram, because, I mean, obviously downgoing renals and extreme renal curves, you know, can get you in trouble. So judiciously choose your access points. You know, it can be done through other access points as well. So it's important to you know, just make sure that you practice good care. So let me just do the Medtronic, the RECOR, the spiral simplicity system. Okay, start audio, please.
One that include the insertion port for the catheter itself. There is a ground pad that also has to be put on the actual ground, and it's its own separate plug. Important, because without this, you won't really be able to generate the.
So obviously there's a pad that grounds, and it's very important that that's on the patient.
Current you need to actually create the full denervation effect. And we have here, you can't see too well because of the lights, but these 4 lights here, now you can see them a little bit better. Okay, right, these 4 lights are basically going to be, the 4 buttons are the ones that are going to be able to use to actually control each of the individual electrodes that are going to be on the spiral catheter. There's a mode to select whether you're working on the right or the left kidney, so the machine also knows, and then simply about how to deliver the actual pulse itself.
Let's go with the run.
This is going to be important because this is going to be how you will be able to select which of the actual electrodes will be doing the actual the delivery of the actual electricity or the radio frequency to do the actual denervation portion, because there are going to be times where you may be having overlapping of the actual electrodes based off the length of the segment of the renal artery that you're going to be treating, that you would actually not want to double treat in a particular area, or if you're at the level of a carina or a bifurcation, you want to limit the amount of energy being delivered over there. The machine itself is again does the bulk of the work. Assuming you have good contact, and again, we'll be able to talk a whole lot more about that, you should be able to deliver the total of the 60 seconds of the therapy. Sometimes what may happen is that you may have issues where you have inappropriate vessel contact, too much impedance, and so on and so forth. And when this happens, the machine will make it very, very clear to you, and it'll turn that catheter off. It'll turn either just that specific electrode off, and I'm sure we're going to run into that here. And it will say that this particular electrode was not able to deliver the full.
I think that's where the efficacy of the whole catheter comes in. You can use on both sides of the vessels and then treat it appropriately.
So now it's the same thing. So what Dr. Sharma was expressing was the differences between the 2 catheters. As Dr. Butt showed you, the spiral catheter has multiple electrodes on the catheter. And the handle, which Dr. Sharma had in his hand, actually has numbered buttons for each one of those cameras, of those points, I should say, for electrodes. And as the device is introduced in, And as you will start to see a waveform on the machine, and the machine will look at how the impedance is, and that is telling you how the contact with the vessel wall is in order to deliver adequate therapy. Unlike the Radiance device or the Record device, which basically has a balloon to oppose it against the wall, here the spiral configuration of the catheter is able to then oppose against the wall. So again,
in
same
all the
technique.
branches as much as possible. I guess the important criteria you talked about is 3 to 8 millimeters, which you have to always consider. And
Entering the catheter into the body now. So just to let you know that it's a standard load of a stiff wire. We changed the wire to a stiffer wire, which is the Grand Slam. And now we're in a 7 French PK1 guide, which is a Medtronic guide as well. And we're going to enter in, and let's see, high impedance. Okay, that's fine. And now we're entering in, and I'm just going to have them just give a little slight puff for me because I just want to make sure which branch we're going into here. That's fine. I'm just going to go up to there, if that's okay with you guys. And then I'm just going to pull the wire out here. Big picture, that's it. So we have a pigtail catheter, which is just a catheter to the level of the very good. So now we're just going
to do the actual denervation.
Millimeters, which you have to always consider. Yeah.
And I think the rest of it. So guys, can we talk a little?
So you can see here now the wire is much more distal than we are with the other device. And you can see because the electrodes are clearly visible here, and these are the points of therapy that you're going to have, right? So with these points of therapy, you want to make sure that you're not across a bifurcation point. So it's very important. And then when you remove the wire, the catheter will then form.
Bit about the monitor, Roman, because it's important for everybody to understand that we don't want to ablate across a branch point.
Yeah, so the first one is really at that distal point.
So now this is the waveforms, as you can see. These are the impedances. And what we're looking for is to make sure that one of these electrodes is not across a branch point. And I'll ask Dr. Butt why later on. And then what we'll do is, you'll see we'll probably end up turning off one of the electrodes here.
And I think that one, for as I think you were saying, it's at a bifurcation point, but it's also where the vessel is becoming pretty small. So really, it's pretty intuitive, kind of just push number 1. And remember, it's important, 1, 2, 3, 4 is not from the proximal to distal, but distal to proximal. So number 1 is the probe that is the electrode that is most distal on your actual spiral catheter. So number 1 we'll turn on, 2 we'll keep on.
That's right.
3 we keep on. 4 I think is also okay. Yeah. So
4 should be fine too.
Yeah. So now really simple.
What about number? I think we keep all 4 on there, guys.
No.
No, 1 is off.
But we would like to keep all 4. I think we'll keep all 4 of them on. I think we can.
Okay.
So 1 is right now is off on the monitor. That's why we see Roman.
1 was actually, we need to be careful that it's not on the carina. So that is probably the reason why they decided to disconnect it. Yeah.
Number 1 is off intentionally.
Yes.
2, 3, and 4 we are keeping on.
Yeah.
So again, the last part of the device, it's just hit the RF button and that's it. Now, as the spiral catheter is doing the denervation portion, the machine itself is doing a lot of the work. Giving the sedation to the patient beforehand is super important. So we're
just going to treat in 4. So what I'm going to do is just rotate it slightly like that.
So what happened there was the impedance fell off and the catheter shuts off. So when the impedance falls off, the reason is there's inappropriate contact with the vessel. So at that stage, you either have, once you look at which lead loses contact with the vessel, and then you go ahead and turn off the ones that have treated, and then repeat the treatment at the level of where the contact was lost. How you ensure contact is by either usually counterclocking or clocking the device, and then rotating the spiral catheter into better apposition and holding it in that apposition and then retreating. So in that manner, just to cut to the chase here, what we did was you wire all 4 vessels and then you treat. Unlike the other device, this device is a 60-second treatment, and usually in the last, I'd say 15 to 20 seconds, they have a lot of pain, and they do feel the pain more than the other device. But again, it's just the mechanism of action. And the same discipline occurs where you go ahead and do a nitroglycerin post and then a completion angiogram. So I hope that was helpful in terms of at least understanding the devices. But if there's any question about, I'm not going to go on with the video, but if there's any question about the devices and how you do the therapy, we're all here to answer. There's one there first.